and the phase 2 trials are almost ready to go at this point. And in the phase 1 trial, we treated a lot of different tumors. There was 40 patients and 13 different types of cancer. So let me give you an update on the phase 3 trial in glioblastoma multiforme. Glioblastoma multiforme is stage 4 brain cancer. Patients typically undergo a routine of radiation and chemotherapy and then adjuvant chemotherapy, and their life expectancy is about in the 15 to 17 months range. And that is pretty consistent throughout all the studies that have been done over the past several decades. The trial design summary is as follows. We target newly diagnosed GBM. So these are patients that typically come into a clinic because they have symptoms, either motor symptoms or speech symptoms, something that indicates that there's something wrong in their brain. They then get a scan and the doctor says, it looks like you have a brain tumor. We think it might be GBM, but we cannot tell. We can only tell if we do surgery, and we recommend surgery anyways because your symptoms will decrease if we operate on you. Those are the patients that we targeted. The trial was the gold standard of phase 3 trials, double-blind, randomized, placebo-controlled, multi-center, and it was run in 4 different countries: the US, Canada, Germany, and Great Britain. We enrolled 331 patients, and those patients were randomized to dcvax L and a placebo. The placebo was also made from their own blood cells, a much earlier stage, and not loaded with antigen, of course. The randomization is in a 2-to-1 regimen, so that it is at least somewhat attractive to the patients because they have a 67% chance to get the dcvax L treatment up front. There's a lot of this trial, all the important parameters are done through central review. We believe that it's important that we take the variability that is inherent if you do things in the periphery, like by the hospitals. You have to make the decisions made by the treating physicians. That there's variability. We wanted to remove that from the equation, and central review will do that. And we applied that to the following parameters. For one, the diagnosis of GBM is independently verified by a neuropathologist. So that we know from, at that point, 2 sources, the local pathologist and the central pathologist, who is an independent expert, that we only admit patients that truly have GBM. Fortunately, the discrepancy between the local hospital and the central review has been minimal. I think we had a few cases, but really very, very few. Then we also monitor the extent of surgical resection. Patients who had a biopsy only were not allowed. And we also determined residual tumor volume to at least later on be able to do the analysis whether residual tumor volume has any impact on the survival of these patients undergoing this kind of treatment. Then we excluded patients with apparent rapid progression prior to enrollment. That was based on preliminary data gathered by Linda Liao and her team at UCLA, who are really the starting group for this particular kind of therapy. And they had found that patients with rapidly progressive disease were making factors that would make it more difficult for an immune response to be mounted. And so we felt that that would therefore create a lot of noise in our trial, and those patients were excluded from randomization. And then disease progression was also assessed independently by a neuroradiologist. We used 2 reviewers for each scan, and there's an adjudicator if the 2 reviewers disagreed. Pretty standard process, but necessary to have a trial of the appropriate quality. Now, I already mentioned that these patients, and I'll go through the screening process later, I mentioned already that these patients go through 6 weeks of radiation therapy with concomitant temozolomide chemotherapy. And after that, we start the treatment regimen. And the treatment regimen is set up as follows. We have an induction phase that is conducted over 3 weeks within month 1. That is really intended to get the immune response started, to get the T cells activated, and to generate enough of the T cells so that when we get to the booster phase, we can truly amplify those activated T cells. Remember that slide that I showed where it goes from one activated T cell that's specific to the target to a whole bunch? That is what is presumably happening in the booster phase. And then the maintenance phase just tells the immune response every 6 months what it is supposed to continue to be targeting, because otherwise the immune response gets occupied with other stuff, and we would lose some of the activity against the tumor. Another aspect of the trial design was the crossover arm. And when we were starting this trial, immune therapy for brain cancer was a foreign and new concept, and it was not necessarily easy to convince patients that it was something that they should be doing. And we therefore tried to make it more attractive to the patients by including this crossover arm. And what the crossover arm means is, first, we make dcvax-L for all patients. And so we make dcvax-L and placebo for every patient that get randomized into the trial. And then they are randomized into either standard of care, and then they get treated with either dcvax-L or placebo. That's the randomization. But then each of those patients, when they hit the disease progression time point, if they do, and that has to be determined by central radiology, then they can go on to dcvax-L. So they either continue dcvax-L if they started with dcvax-L, or they change to dcvax-L if they started on placebo. And you can see how attractive that was to the patient, because at this point in time, approximately 90% of patients in the intent to treat populations have been treated with dcvax-L. However, when we did that crossover, or when we kept patients on dcvax-L, they were given the same treatment regimen, and we did not unblind the investigator or the patient. So it remains an unbiased trial, even in the crossover arm. All the investigator knows is that they're all getting treatment, but they still don't know what they were originally randomized to. The endpoints of the trial, we had one primary endpoint, progression-free survival, i.e. survival until documented progression of disease, and one secondary endpoint, overall survival. And we did power the trial for both endpoints independently. So these are not co-primary endpoints. If you're a statistician, then you know that if you have co-primary endpoints, you have to split the amount of statistical power you assign to each of the endpoints. These are independent endpoints, and they're powered independently. And then, of course, we have a lot of supportive or tertiary endpoints, and that includes immune responses to the tumor, immune responses to dcvax, decline in performance status. We have landmark survival analyses, let's say survival at 1 year, survival at 2 years, and time to progression as well, which is slightly different from progression-free survival, because in time to progression, you only count tumor progression events and you don't count death as an event. So it's another measure of drug efficacy. This is the screening period that I alluded to, and it's important to walk you through this. But it's likewise important to understand that there's a 3-month period, approximately, between initial identification of the patient and consenting the patient to potentially participate in the trial and actual enrollment. That's important to keep in mind. Every trial is a little bit different, and every trial has a little bit different enrollment time point. And one can report data from those different time points, but it's important to understand how they refer to the overall treatment and the natural history of the disease. So walking you through this, the patients come in, like I said, just before surgery. They get signed a consent form. The consent form really only says, are you willing to donate your tumor for clinical research, which could include participation in a clinical trial. So almost every patient agrees to that. I don't think we've had many that said no. But what you will understand at this point is that we don't know yet whether those patients have GBM or not, because that will only be determined by pathology. So there's patients going to screening that we lose later on because they never had GBM. Then they go through surgery. Sometimes the surgeon is able to take out a larger tumor. Sometimes the surgeon can only do a biopsy. Those biopsy-only patients would be excluded from our trial. Very small tumors would probably be excluded from our trial. I'll talk about that next. The patient then undergoes the leukapheresis. This is the 4-hour blood draw where we collect the white cells. And then they go through their period of radiation plus concomitant temozolomide of about 6 weeks. After that, we do the baseline screening, see if they have progressive disease, like I talked about before. And then those patients that don't, they get randomized and they get their first dose. What happens in the background is that the tumor is sent for tumor lysate preparation to our manufacturing partner, Cognate Bioservices. they make the tumor lysate from the tumor tissue. Sometimes it happens that we don't get enough tumor, and we have a threshold. If we don't get a certain amount of protein, there's no point in proceeding with the leukapheresis. So there's a few patients where we don't have enough vaccine, we don't have enough protein, because their tumor is just too small. But that doesn't happen very frequently. We don't need much tumor to make the vaccine. After leukapheresis, the leukapheresis product is sent also to Cognate Manufacturing, and they manufacture the dcvax L product, which then goes through extensive product release by quality control, immunophenotyping, a functional potency assay, et cetera, the standard parameters. But in our case, they're pretty stringent. We need a high purity of dendritic cells, and we need a high dendritic cell T-cell interaction activity. So we're typically looking at 85% purity of our cells. So we know at the point that we start immunizing them that we have the right cells and that we have enough cells to immunize. The doses that we're giving are 2.5 million cells per immunization. Main reasons for screen failure are as follows. I mentioned a not GBM, I mentioned a tumor too small. Occasionally, white cells will not cooperate. Depending on the status of the patients, there are patients where we just cannot get the monocytes to cooperate and become dendritic cells. We don't know all the factors for that, but we know, for instance, that some patients who cannot be weaned off of steroids therapy after surgery, it's difficult for the monocytes to be purified in the system that we use. So we lose a few patients because the leukapheresis or the cells don't cooperate, and then we have the progressive disease that I already highlighted before. This is our enrollment timeline. I don't think we have mentioned this before. We started this trial in June of 2008, and that seems a really long time ago. But if you look at this graph, we only recruited up to 20 patients here. This is percentage enrollment, so this is about 20 patients. And then it really took off late 2012. So we're really talking about an enrollment period of 5 years, and the midpoint was hit in May of 2014. We think this is a relevant parameter, and I think you'll see why. So here's an update with some metrics that we have not shared with you before, that will give you a good sense as to where we are with this trial. And remember that median overall survival for patients with GBM is 15 to 17 months from diagnosis. We enrolled the last patient in this trial 19 months ago, and we screened the last patients 22 months ago. Remember that period of 3 months between screening and enrollment. And the median point was 37 months ago in May of 2014. I mentioned that on the previous slide. I also mentioned that about 90% of all of these patients have been treated with dcvax L, and at this point, approximately 100 patients are still alive. The consequence of that is that we have had 231 OS events. 231 patients are deceased on the trial. And we had specified that we need a minimum of 233 overall survival events before we will conduct the analyses. And that threshold is anticipated to be reached in the first half of July of this year. Because we are running currently at a rate of 2 overall survival events per month. Now, I'm aware of the fact that we have announced earlier in December of last year, I think, and also in February of this year, that we were close to hitting this particular event. But it turns out that the death rate at this point in time is lower than we had anticipated. And so patients are living a little bit longer, which is why it has taken us longer to get to this point in time. We are currently working on a publication of a preliminary analysis. It's in preparation with our investigators, and I think you will find it interesting when that publication comes out.